Hello, my name is Chris Moore, and I'm here to talk to you about the second part of our series on focused emergency echo. And this is part 2, pathology and pitfalls, the 5 E's that we'll talk about. If you haven't done so, I do recommend that you watch part 1, which talks about indications, normal anatomy, and approaches. So when looking for pathology, I think it's helpful to organize your thoughts about things that you're looking for. And occasionally other things may pop out, but if you do this in a systematic way, these are the things that, in my experience, I think emergency physicians can learn to reliably differentiate, at least categorically, and can be very helpful in clinical situations. The 5 E's are effusion, is there a significant one? Ejection, how is the left ventricular function or squeeze? Equality, how does the right side compare to the left side? Exit, which refers to the thoracic aorta, looking for pathology, dilatation, or dissection. And entrance, which is the IVC entering the right atrium. Looking at the IVC can help you tell something about hydration status. So pericardial effusion is certainly the one of the first indications for the use of emergency echo, and it can present in a wide variety of ways, with isolated dyspnea, tachycardia, hypotension, or chest pain. So pretty much all of the indications for echo could include looking for a pericardial effusion. You can get it for a lot of different reasons. Certainly the most dramatic is penetrating trauma, and the ability to tolerate the amount of fluid around the heart really depends on how fast it accumulates and whether the body can respond to it. So an effusion like the one shown in this video that's quite large would probably have collected over several days to weeks, whereas in penetrating trauma, a very small effusion can actually cause hemodynamic collapse. The hemodynamic collapse is called tamponade, and that's really a clinical diagnosis of low blood pressure that comes from right heart collapse when the right heart is actually restricted from filling, and we'll look at that in more detail. So the first thing when you're looking at the heart is to decide, is there a significant effusion? And as the machines have gotten better, a lot of times you can see sort of an echo-free or at least darker space anterior to the heart. And this is especially true on the parasternal long axis image. But you need to refrain from calling this as a significant pericardial effusion. So when we look at this view, there is sort of a hypoechoic space between the liver and the right ventricle here, but it disappears completely in diastole and really is not completely echo-free either. So this is indicative of epicardial pericardial fat surrounding the heart, and this is frequently seen particularly on a parasternal long axis view. So I really recommend that you do a lot of echo on normal people so that you understand the spectrum of how pericardial fat can appear on ultrasound or echo. Now this is a view, a subcostal view through the liver, providing a nice window, and there is an effusion here. It's truly black. You can see it going all the way, trying to get around the apex of the heart. There's no other echoes in it. However, it's not very large. It certainly doesn't appear to be indenting the right ventricle. So this is a good example of a small and real effusion. The subcostal view is the best way to detect an effusion, as it looks from the inferior upward, so that fluid which collects inferiorly will be closer to the face of the probe or the top of the screen. This is an apical view of an effusion that is circumferential. It also appears to be collapsing the right atrium somewhat in systole, although you have to watch out for atrial contraction. But this is a moderate to large size effusion. And when we differentiate these at our institution, basically we're trying to say is an effusion small, which would be 1 centimeter or less, measured at the largest point in diastole, or is it moderate to large, greater than 1 centimeter. You can also differentiate moderate from large, moderate being 1 to 2 centimeters and large being greater than 2 centimeters. So we mentioned tamponade, which is basically when the fluid around the heart compresses the right side of the heart, either ventricle or atrium, preventing it from filling. This therefore prevents blood from getting to the left side of the heart and causes hemodynamic collapse. In this clip here, you can see that the free wall of the right ventricle is being indented by the fluid that's surrounding the heart, and that's seen clearly between the right side of the heart and the liver. This is a subcostal long axis or sagittal view. On the right side of the screen, about the middle of the screen, you can see the inferior vena cava, and it's draining into the right side of the heart. You'll also notice that it's not collapsing well. And if you look closely just above the liver, you can see a significant pericardial effusion. The lack of collapse of the IVC actually indicates tamponade physiology because the blood is not able to flow into the heart due to the extrinsic compression, so it backs up into the IVC. It's sort of the sonographic equivalent of jugular venous distension. If you want to get a bit more advanced on diagnosing tamponade, you can use Doppler. And really what you want to look for here is the mitral inflow pattern. You can do this by first placing color flow Doppler across the mitral valve and then a pulsed wave signal at the tips of the mitral valve. When you look at this signal, what you normally see is an E and an A wave, early filling and an atrial kick, which are the two peaks seen here. However, it usually doesn't vary that much from breath to breath. If there's a variation of greater than 25%, that's indicative of tamponade physiology. And this actually shows measurement of two E waves at different cycles of inspiration, and clearly the second one has dropped by close to 50%. This is basically the sonographic equivalent of pulsus paradoxus, which is when the patient takes a breath in, there's reduced filling on the left side of the heart. Great article on this in the New England Journal of Medicine in 2003. When looking for pericardial effusions, you do need to be in pitfalls, specifically fluid that is adjacent to the heart but not actually in the pericardial space. This is a short axis view of the heart, and you can actually see the heart sitting up against the spine. If you look at the right lower corner of the screen, just below the left ventricle, you see fluid, and there actually appears to be something in there, perhaps a collapsed lung. But the point being that this is actually a pleural effusion or hemothorax. You can see that it's the fluid is placed laterally to the descending aorta, which we will point out on some other images. But whenever you see fluid adjacent to the heart, especially if it doesn't go all the way around, think about pleural effusion or hemothorax, and take a look in the chest cavity as well, similar to the way you might do in a FAST exam. So these arrows here are pointing to the same structure on two different patients, both in a parasternal long axis view. And the question is, what is that structure? And I want to draw your eye to it when you get a parasternal long axis to recognize this. And this is the descending aorta. And the key here is that the descending aorta can help you differentiate where fluid is, especially on a parasternal long axis view. If you look closely, there's a collection of fluid on each of these images. However, the difference is on the left sided image, the fluid interposes itself between the heart and the descending aorta, which is indicative of a pericardial effusion, while the pleural fluid, noted on the right side, tracks around the aorta and not between the aorta and the heart. So that's a useful way to differentiate pleural from pericardial fluid. Again, it's also helpful to take a look in the chest spaces to see if there is a pleural effusion. This is a clip of an apical view. You can see the descending aorta sitting against the spine there, and this patient actually has both a pleural effusion and a pericardial effusion. You can see the pleural effusion fairly large to the bottom right of the screen, and you can see the pericardium outlining another fluid pocket that's within the pericardial space. So this is a pericardial and pleural effusion. In particular, on the left side of the heart, you need to beware a left pleural effusion that could appear as if it's surrounding the heart. This is an example of one where the fluid is in the left chest. It is not seen to extend around the entire heart. And again, if you looked in the left coronal view up high, you should see the left pleural effusion delineated well by the diaphragm. Okay, moving on to the second E, and this is ejection or squeeze, and it's asking how well does the left ventricle squeeze. This is a pretty clear example here of two hearts, one on the left that is squeezing very well. In fact, it's hyperdynamic. And there's another one on the right that's dilated and not squeezing well at all. Sometimes they're this obvious, and then there's some other shades of gray, but ideally you should be able to at least distinguish qualitatively between hearts that are doing well and hearts that are doing poorly. And when you really think about this, it's a spectrum. When you have somebody that comes in hypotensive, sort of the very far end of that spectrum is pulseless electrical activity or a code situation. And there's an article published in AEM in 2001 that states that if there is absent cardiac activity, the patient is very unlikely to survive, amazingly. So when you look at the heart in a cardiac arrest situation, you're looking for significant myocardial activity or motion. One thing to be aware of that we'll look at is agonal valve motion. When you are categorizing the ejection or the squeeze, would recommend using a three-tiered system. Category 1 being an ejection fraction of greater than 50%. Category 3 being a severely depressed left ventricle with an EF of less than 30%, and moderate being category 2 or 30 to 50%. You also can add categories for hyperdynamic, which you may see in sepsis or dehydration, and absent cardiac activity, as in a code situation. So we've seen a couple examples of really severe LV dysfunction and good LV function. This is an example of an apical four-chamber view showing an LV cavity that is moderately depressed. It's not as vigorous as some that we'll see, but it's not severely depressed or severely dilated. And these can be a little bit more difficult to discern. The other thing you have to be aware of is the possible presence of focal wall motion abnormalities. And when possible, you want to get as many views of the heart as you can. The short axis in particular may help you with this if you can scan all the way through the heart. On the left side of the image here, you can see that the septum is not contracting well, while the apex and the lateral wall are doing okay. The right side of the image shows an area of basically akinesis in the apex of the heart. The apex is really not moving at all, and at times this can actually progress to aneurysm. Point being here that these can be difficult to pick up, usually outside of the scope of EP-focused echo, although they may be blatantly obvious, but beware of them if you're trying to get a global view of how the heart is doing. So in this image, it's a parasternal view, and we want to look at the left ventricle, and you can see that it's vigorously contracting. The other thing that you can keep an eye on is the valvular motion of the mitral valve. Vigorous motion suggests a good squeeze. And this was actually on a septic pediatric patient in Uganda with severe pediatric malaria. Here's an adult who came in with dyspnea and cough, and taking a look here, you can see that the left ventricular cavity is dilated and very hypocontractile. Also taking a look at that mitral valve, you can see that it's really just not moving very well. This is another example of that far end of the spectrum where there is some valvular motion, but really no significant myocardial contraction. And if you actually look at this valve, the one you can see best here is the tricuspid valve. It's actually not closing completely. And if the valves are not closing, especially with minimal cardiac activity in the actual myocardium, it indicates a heart that's probably not going to be compatible with life. So watch the valves and see if they close, and look for significant myocardial activity in a code situation. Okay, we're moving on to our third E, which is equality, and that's really just looking to see, is the RV as big or bigger than the left ventricle? And this can be particularly helpful if you're concerned about pulmonary embolism, although it's neither sensitive nor specific for PE. You can certainly have PEs that don't have RV strain, although the ones that are very significant do tend to have it. And you can have right heart strain that's more chronic from pulmonary hypertension or COPD. But the presence of RV strain should alert you that there's some process going on in the lungs, and we'll talk about some clues to differentiate acute from chronic processes. When you think about the right side of the heart, it's really kind of wrapped around that left ventricular cavity as shown in this short axis schematic. On a long axis, it's more triangular. So it wraps around the heart and normally is smaller than the LV cavity, certainly as measured across the tips of the valves in the apical four-chamber view. And a normal ratio, if you measure it here, would be about 0.5 or 0.6 to 1. So more than that is considered abnormal. However, in order to try to stay fairly specific and not overcall pathology here, we generally use a cutoff of 1 to 1 or greater. One thing to note is it's really important that you orient your probe correctly so that you understand which side of the heart is which, because if a pathological heart appears, you can't just look at the image necessarily and determine which side is the left and which side is the right. So it's really important to be oriented in order to make this determination. So here's sort of a high subxiphoid, low parasternal view that shows an LV that's doing fairly well. It's contracting okay, but the right ventricle is dilated and hypocontractile. The apex does appear to be moving some in this case. It's not the best example, but this is an example of a McConnell sign where you have RV hypokinesis with a spared apex. The apex is moving, but the mid portion of the RV is not, and that's fairly specific for pulmonary embolism. So, like we talked about, you can have RV overload with more chronic processes. One thing to be aware of is that with a chronic process, you'll actually get hypertrophy of the right ventricle. A normal RV free wall is going to be under 5 millimeters in width, but with hypertrophy over time, you can get a very thick right heart. And this is a patient who presented with actual collapse and hemodynamic instability. There was a concern for PE. However, he had a known history of pulmonary hypertension. In this case, he actually did have a PE as well. But looking at this right heart, you can see that it's quite thick. The free wall looks to be at least a centimeter. You could measure it if you want, and that indicates a chronic right ventricular process. This is a good example of paradoxical septal motion. You've actually got what they call the D-shaped septum, which is best seen in a short axis view, where the septum becomes flattened because of pressure overload on the right side. And you can see that the septum is just not moving the way that it should in a normally functioning heart, and the RV does appear enlarged. So this is a better example of McConnell sign. In this case, you can see the right heart is massively enlarged, but the apex is actually moving quite well. The tip of the heart, where the probe is placed, is contracting, but the mid portion of the RV is dilated and hypocontractile, indicative of an acute pulmonary embolism. Here's another example in a short axis view of a D-shaped septum where that RV is really compressing the LV, making it quite small. You can see why a patient might be hypotensive in a situation like this. Okay, moving on to our fourth E. This is best measured at the parasternal long axis. You're looking at the exit, which is the thoracic aorta. You want to measure outside to inside. Normal is less than 4. We generally consider abnormal to be 4.5 centimeters or over, with borderline being 4 to 4.5. You will sometimes get somewhat different measurements on a CT scan, but being aware of thoracic dilatation can help clue you into the fact that there may be a thoracic aortic aneurysm or dissection. Aneurysm is certainly a risk for dissection, but not all aneurysms dissect, and not all not all dissections are aneurysmal, so you can't use it completely to rule one or the other out. You also have to beware of the ascending aortic arch and sometimes the descending aorta, which may not be visible on this view. This shows the measurement of the thoracic aortic root. Here's another measurement. In this case, a patient that did have a thoracic aortic aneurysm. It's measuring here at 4.65 centimeters. Thoracic aortic dilatation certainly can be a risk factor for dissection, as seen in this CT scan. And if you look closely in this apical four-chamber view, you can see that there's actually a flap right at the aortic root in the center of the heart. And transthoracic echo can be fairly specific for dissection if you see it, but is not sensitive to rule it out. You should get a CT or a TEE if you want to rule it out. This is a suprasternal notch view where you follow the carotid down into the aortic arch, and in this case we can see a flap, and this was an acute aortic dissection as well. You do have to beware of the SVC and other vascular structures in this area, but if you actually see a flap within the aortic arch, again, specific for dissection but not sensitive enough to rule it out. This shows a patient with a subxiphoid view of the heart where there is a large pericardial effusion, actually with clot in it. That's why it's somewhat homogeneous and not completely anechoic. The thoracic aorta is seen in the middle of the heart here to the left as in a peristernal view, and it is dilated above 4 centimeters. And this patient came in, they collapsed acutely from a thoracic aortic dissection, which can't be directly visualized but is suspected with the presence of a dilated thoracic aorta and a pericardial effusion. This patient was sent directly to the OR and actually did well with a graft. As mentioned, on the peristernal long axis view, you can often see the descending aorta, and it's important to keep your eye on that as well. In this case, the aortic root is seen to be fairly normal, but you can see a very dilated descending thoracic aorta sitting just behind the left ventricle and left atrium on this view. So just keep your eyes open for that as far as thoracic aortic pathology as well. This is our fifth and final E. The entrance to the IVC can be considered part of the cardiac exam and certainly can be integrated into other goal-directed examinations, such as patients that have shortness of breath or hypotension. Generally, you want to get a subxiphoid long axis view. You can measure the IVC. You want to go about 2 centimeters away from the diaphragmatic inlet. The overall diameter, generally normal, is under 1.5 to 2 centimeters. Over 2 would be considered dilated. And you can also look at the percent collapse or caval index. Sometimes reported as a 0 to 1 scale or 0 to 100%. If it's very collapsible, it indicates that the patient is fluid depleted, whereas if it's non-compressible or non-collapsible, the patient is fluid overloaded. And M mode may be helpful to look for the respiratory variation in the IVC. This clip shows a very dilated and not collapsible IVC. It's really just not moving at all with inspiration. This indicates the patient's fluid overloaded. Here, on the other hand, is an IVC that's not very dilated and also collapses with inspiration. So this patient is on the drier side and certainly not fluid overloaded. This shows an example of using M mode across the IVC. Ideally, you want it to be perpendicular to the two walls, and then you can watch the M mode to see the degree of variability and actually measure it to calculate a caval index, if you like. As a general guide, as we talked about, IV size greater than 2.5 would indicate that there is a fluid overload status, and respiratory changes that indicate total collapse would indicate a patient that's dry or with a low CVP. Again, if the IVC is dilated and not changing with inspiration indicates a high CVP. Some people have tried to look at this really quantitatively. In my opinion, it's probably better in a qualitative sense if we're looking for somebody who's very dry or very wet or in between. We also mentioned this in the presence of pericardial effusion or pericardial tamponade. It's good to take a look at the IVC. It should be dilated if there is tamponade physiology, again, sort of the echo equivalent of jugular venous distension that you'll see with pericardial tamponade. So to summarize, the 5 E's: effusion, ejection, equality, exit, and entrance. I really recommend that you try to get an idea of what these look like on a lot of normal people. You may see occasional other pathology, but be careful with some of these things because they can be tough. And if you really get into a systematic way of evaluating these 5 things, I think you'll be able to find things that can be helpful in care of your patients. Again, really important to know your anatomy and orientation, particularly when you're trying to evaluate the right side of the heart. Make sure that you know which way your probe is and making sure that you're looking at the correct RV and LV. Know your anatomy. Get as many views as you can, especially for pathology. Beware the pitfalls, especially false positive pericardial effusions from fatty tissue or fluid in other places. You want to completely visualize as much as you can, beware some chronic conditions, and practice, practice, practice. So good luck, and please feel free to email me with any questions or comments. Thank you.
This one's